right, question 5, the clinical scenario. A patient with new onset AFib is admitted. How would you approach their anticoagulation? You most certainly will get a clinical question. It might be a formal case or it might be a spontaneous one like this. They aren't always looking for the right answer, especially since guidelines change. What they're really testing is your thought process. They want to see how you think on your feet. Can you walk them through a problem step by step, gather the right information, come up with a safe, logical plan? Don't just blurt out a random drug name. Walk them through your process out loud, if you can. Assess and gather information. Okay, my first step would be a full patient workup. I'd confirm the new onset of AFib diagnosis and check the patient is hemodynamically stable. Then I dig into their chart. Past medical history, all their current meds, allergies, baseline labs, paying close attention to kidney and liver function, and any history of bleeding. Use your tools. Next, I calculate their CHADS to VAS score to figure out their stroke risk and their HAS blood score to see their bleeding risk. That data is essential to decide if anticoagulation is even the right move. Next, make a recommendation and justify it. Assuming their CHADS to VAS score shows they need anticoagulation, then I think about which agent to start using. Based on current guidelines, a DOAC is usually preferred over warfarin. My choice between something like apixaban or rivaroxaban would depend on the patient's kidney function, potential drug interactions, and ultimately what their insurance is going to cover. Plan for follow-up. Finally, I create a monitoring and education plan. That means counseling the patient on why adherence is so important, what signs of bleeding to watch out for, and any follow-up they might need. I document my recommendation clearly in the chart and communicate to the rest of the medical team. This structured approach shows you are a safe, methodical, and thorough